Hey everybody, this is Todd from Beyond Type 1, the Director of Content. It is Wednesday, April 15th at 11:30 a.m. and I am here again with Dr. Ann Peters from the University of Southern California to answer some of our community questions about COVID-19 and diabetes. So Ann, can you quickly introduce yourself?
Yes. Hi, I'm Ann Peters from the University of Southern California, where all I do is take care of people with diabetes. And right now, I'm helping all the people I can get through this whole COVID epidemic or pandemic, which, by the way, is something we're going to be talking about for a long time to come.
How long do you think, actually, let me just ask you that quickly. Do you have any sense of how long this might all be going on?
Well, let me talk about something that we hadn't even talked about talking about. But the notion is this is going to last until well into 2021 and maybe 2022, because we have to come up with a good vaccine and or a good treatment. We have neither. But one of the ways in which we're going to return to a somewhat more normal life is going to be through this notion of being able to capture cases of COVID-19 and then quarantine them and containing it within communities. And because it's not going away, we just have to be safe and not catch it from someone. That being said, there's two tests. There's a test called a PCR test, which tells you if you have the virus in your body. And we've gotten good at those PCR tests, and that's the way we've been finding out who has it. But the second test, and the test that all of us want, is an antibody test. And that test tells you not only if you have it now, because that's something called IgM, but if you have had it. And we don't quite know what that means exactly in terms of how long you might be immune to it. But we do know that if you have something called IgG, an antibody that tells you you've had it, it can confer at least partial immunity for a while. So any of you who have an antibody test that's positive for IgG, you may be at much less risk and you may be able to go forth in the world. But we don't even know the rates of people who've had it because we haven't had those IgG tests, the serology tests out. What's happening is that everybody and their brother has come up with one of these tests. And the reason you can't trust a test yet, unless it's validated by the FDA, and there's only one validated test and that's not available yet, or through research, is because there's many different forms of a coronavirus. So you could take a test that says, yes, you have IgG, but if the person making that test didn't make it specific enough, if it doesn't pick up SARS coronavirus 2, that's what makes COVID-19, it could mean that you had a head cold a year ago and that's what it's catching. So what we know now is that you have to make a good test to get a good answer. So any tests out there now are pretty much tests that somebody developed in their basement and said, here, let's just see it. So it's not yet time to go get your antibodies tested. They're doing tests, for instance, in LA County, they got a test that seems good, and we're testing 1,000 people just to look at the distribution of the virus. And I want to do a study looking at the distribution of virus in patients with type 1 and type 2 diabetes and looking at how it affects people with diabetes. I'm going to do all of this, but not yet. We have to wait till there's a good test that we can then use. The one they're doing in LA County for those 1,000 people is a pretty good test, but in LA, I've just seen people get the wrong test and they get these weird antibodies and don't do it yet. So you want a serology test to know if you're, Superman, if you can go out in the world. But the tests aren't yet ready for prime time, but they will be within a month or two.
Okay, that's actually really great information for me. I've had a couple of people text me links to private tests that you can go get for $125 in the Bay Area. That claim to be able to tell you if you've had it or not, but you're saying until there's an FDA approved test, we can't trust any of these ones that are out there?
Well, you can't know which ones to trust and not, and that's the problem. And if you can't trust a test and it tests positive for IgG, you don't know what that means. And what if it's wrong? I mean, what if it's tested for the wrong coronavirus? The point is we've all been this darn careful. Keep being careful, because I just don't want people to get the wrong advice. And the FDA did this weird fast track thing, and they basically gave a lot of people the option for using or disseminating tests, but they're actually not FDA approved. So they haven't been proven. So don't get an unproven test. Like I said, you can get any test. I can get anybody a test out here, but it doesn't mean anything yet. Just wait. And some of them are going to prove to be good. But since you can't tell, when I read the fine print on these tests, they're just not adequately validated. Science is science. Science takes time. I mean, I know we want everything to be faster, and people are working really fast, but there's some hard limit. Like, does it really work? I don't know. You got to know that. Does it really prevent the disease? Does it really treat the disease? Some people seem to think they can just will things to work, but you can't just will something to work. It actually has to work.
Great, excellent. Okay, so I'm going to pivot a little bit. We've had a lot of questions now, and I think this is related to people knowing that this is going to be a long-lasting thing. We're kind of in this for the long haul. So we've had some questions, and we're trying to develop some type of consensus about when it's appropriate to seek emergency medical care. We're trying to keep people out of the hospital as much as possible. One, to not overwhelm the system, but also so they don't risk exposure. So I guess just generally, and then I can ask you some more specific questions. Have you changed any of your care recommendations based on everything that's going on to people treating themselves at home, or about when to seek emergency medical care? I guess, and then specifically like in regards to DKA and ketoacidosis, and then also for severe hypoglycemia is the other time when we might really see people seek that type of care.
Well, my fundamental theory is that I can keep almost anybody out of the hospital if they have access to health care and somebody who knows what to do. I won't even go into detail about whether or not I think people can do this, but my own personal belief is that it's inherent upon everybody with type 1 diabetes to have ketone test strips at home. Urine ketone test strips are fine. But the reason you need that is because an unexplained high glucose level, especially if you're feeling sick, if it's associated with increased ketones, moderate or above, means you need carbohydrates and insulin. And usually you have to double your correction. And there are a lot of people out there who don't do dose adjusting. Those of us who teach this and those of you who do this know what I'm talking about. But I know a lot of type 1s who don't. But the point is that ketones mean you're resistant. Resistance means more insulin to get rid of ketones. And then I also think that people need to have some antiemetic. And I'm not sure all doctors prescribe this, but if you can't keep down fluids, that's the first thing. But then you have to go to the emergency department, because if you can't keep down fluids that have glucose in it, then you can't give insulin, you have to go to the hospital. So as soon as someone's vomiting too much, they just have to go. They just have to go, and they shouldn't wait. But early ketones and moderate ketones, I can usually dose people through. And again, some people just get a horrible gastroenteritis. This has nothing to do with COVID. This has to do with, you ate at a restaurant, or these days got takeout that in some way had, something in it that made you sick. So I can't keep everybody at the hospital, but most I can. And so I think it's really important to have ketones sticks at home. If you're on a pump, you have to have syringes and injectable insulin. Have something so you're not vomiting, and then have glucose-containing fluids. But there are other two things that I've learned really help me. And this is not just for people with diabetes, but if you have hypertension and you're young and healthy and don't, I'm assuming, but anybody who has hypertension should actually have a blood pressure cuff at home, because doing remote managing hypertension is something I can do remotely as long as I have blood pressure readings. And if you it's better to catch them at home anyway. So I tell everybody who's got hypertension to have a blood pressure cuff at home. And then, I know this sounds Pollyannic, but it really helps me to help manage somebody if they have a sensor. So if they have a Dexcom or a Libre, a continuous glucose monitor, that I can look at on Tidepool or Clarity or whatever I have to look at it. But I really find it helpful to me, and there's a lag in some of this, but if I have somebody who's in early ketoacidosis, if I can just see their glucoses in real time, it's really helpful to me to adjust their insulin and help them through it. So, and I think it's also, I've had some patients where they've been sick with presumed COVID-19 and they're home because of this, and their mother's in the next room. They want to be able to share so that the mom can actually help. I mean, the more help you can get managing illness with type 1 diabetes, and particularly if someone gets COVID-19, I mean, people feel pretty darn sick with this. The more people can help you, the better off it is. So I think just having the ability to use a continuous glucose monitor and share it with family members or physicians is something that I really advocate. I always really advocate CGM, which is, don't get me wrong, but there are a lot of people who don't still have it. And honestly, in the time of sickness, that for the next year and a half, when people could get sick, it's so much easier to monitor at home. And then the FDA has given a special clearance to use CGM in the hospital. So if you go to the hospital and you have CGM, a nurse can stand outside your room and look at your glucoses and help adjust things. So to me, everyone should have CGM to help them through this period. I'm just, I don't usually push things on people, but right now I do. And I just think those are the tools. So ketone test strips, something so that people don't throw up, ability to give injectables, and a sensor if that's at least vaguely possible. And have this all in advance, because it's really hard for me to get people new CGM systems because I have to do paperwork and my printer stopped printing. You know what I mean? I'm not at work. It's a problem.
So you did say that you're not sure if doctors all prescribe an antiemetic. Is that something that you would need to get prescription, or they're good over-the-counter antiemetic?
It's a prescription drug.
Okay.
See, I can't give it in my LA County patients, the underserved. I can't give them ketone test strips. You think that the people who are in that category would be the most likely to need this because their diabetes is much more poorly controlled. But, once I'm not running around so much, I'm going to make a policy change. The county has to give everybody with type 1 urine ketone test strips. I'm just telling you, it's got to be part of the protocol. And they don't in advance give antiemetics. But again, these are the things that let me keep people out of the emergency department. And you don't want to go to an emergency department because you could get coronavirus there. You don't want to be there. And it also slows up the system because people with diabetes are so much harder to treat because of the need for finger sticks.
Absolutely. So you did say, if someone's just vomiting, they can't keep food down, then they are going to need to go to the hospital. Is there any other kind of guideline or line that crosses, like once they have large ketones for a certain amount of time, or anything specifically where you would say this person definitely needs emergency care versus you can probably treat at home?
Well, no. If somebody can keep down fluids and I can give them insulin, I can keep them out of the hospital. It's the keeping down fluids part. It's the, can you ingest carbohydrates as a substrate for the insulin? That's all we need to give somebody. And you can have large ketones. I mean, even non-diabetic people could get large ketones, but it means a different thing. But I just feel like if you can keep down fluids, but if you even don't have ketones and you can't keep down fluids, then I would, you know what I mean? It's about the, can you keep down the fluids and the carbs? The other things that would make me send people to emergency department are obviously other things, like if you're having crushing chest pain or, something, older patients get cardiovascular events. And we've seen people, even kids in both Italy and in the United States now, who have new onset type 1 and the parents don't really know what's going on, but they keep the kids at home and they don't take them to the emergency department and they end up sicker when they get there. So you can't be completely scared of an emergency department, but if we can prevent it, obviously that's a good thing.
Absolutely. And I did want to ask about the other end of the spectrum, which is severe hypoglycemia. I think guidance on glucagon is that anytime you use glucagon, you should call 911. I know from experience, I know in the community, that's definitely not always the case. I mean, people are using mini doses of glucagon or they're using it on their own without the need for emergency care. What do you tell your patients in terms of using glucagon or treating a severe hypo? Is emergency care required? Should you still call 911? Should you call your medical provider anytime you use glucagon? I guess, what is your advice there?
It's a very good question. So this is the deal. You see, it's very complicated because I, in general, don't want people to call 911. You can call 9. So if you have a severe hypoglycemic episode and you're on the floor and somebody gives you glucagon and you wake up and you can eat, you can go back to normal, I don't think there's any need to call 911. Why? Now, if there's some weird reason someone got low, like they got low and they fell off a ladder and broke a bone, then you could call 911. But honestly, severe hypoglycemia to me is a treatable process that doesn't require 911. Calling 911 is complicated. Most of the time, they're not going to want to transport you But even if they do that, it's going to put you in an emergency department and they'll forget to feed you and then you might go low again. So anyway, I'm a big advocate of home treating your severe hypoglycemia. 911 nowadays is much less likely to transport you to a hospital, and they're just going to say, what do you need us for? And I've had patients call 911, even patients who I thought should be transported because they were sick for other reasons who didn't get transported. So I would say have glucagon on hand. If you can have inhaled nasal glucagon, that's my preference. And more and more insurance plans are paying for that. So I would try to get that to have at home, but certainly injectable. And don't call 911 unless there's some overwhelming need to do it. Most of the time, it seems to the person who's treating the patient with severe hypoglycemia like they're never going to wake up, right? It's going to take 10 to 15 minutes. But for most cases, again, unless there's some other injury or prolonged seizure or some other thing happening, I wouldn't call 911. The other thing is, and this is just a technical thing, is that if someone calls 911 and they go to the hospital, it's like having a seizure. It's supposed to be reported about the drive so that you don't drive. And then I can undo that by saying, if you're actually had a reason for the severe low, whatever, but we don't want people with severe lows driving either. But I also am not personally punitive in the sense of just because you had a low because some other extenuating circumstances happened and you're working with me, then that's okay. But there is that whole notion of really addressing why you had the hypoglycemia, if it should result in some sort of restriction on driving, and how do we resolve that? And to me, that's something I want to resolve with my patients. So I want to know if someone had a severe episode. They don't even have to call me that day, but I want to know sometime within, a reasonable time frame so I can discuss it, treating it, driving, every other thing that I might want to discuss. So I think it's something one should mention to one's healthcare provider in near real time. But the key is just to treat it at home and then, eat something and, go about your life. But if there's some weird situation, then that might require more urgent care. But most of the patients won't be transported and it'll just be a waste of the emergency system. And people will come in and have masks and gloves and be crazy.
All right, great. So I think you've provided a lot of great advice on keeping people out of the hospital, and obviously that's what we're really striving to do. But I know that you've also spoken a little bit about, just in case you do need to go to the hospital, the importance of having sort of a to-go bag ready, or a kit of sorts. Can you talk a little bit about maybe what you would include in this to-go bag and why it is important for people with diabetes to just be prepared?
Well, part of the reason, the big reason, well, there are two big reasons. One is because it's been very hard for hospitals to test blood sugars because they have to put on new PPE and go in and have a whole suit because of the concern about COVID. And I think that anytime somebody with type 1 diabetes goes to the hospital, even without COVID, it's good to have everything you need with you. But the reason it's particularly important now is because family members can't come to the hospital and see you if you have COVID-19. And you want to make sure that, because everything plugs in these days, that you have your charging cables and a charging cable for your phone, because people get there and then their phone dies and they can't reach people. So it's important to be able to charge your phone, your iPad, whatever you use to communicate, as well as your devices. And then it's important to have, extra sensors, extra infusion sets, extra of anything you might need to run whatever technology you can run in the hospital, as well as the SMBG, the strips, the Lancets, the meter, just to be able to take care of it. If you think about it, I think the scariest thing in the hospital is loss of control. And for everybody with type 1 diabetes, they have within their skill set the ability to control that portion of it. If you get very sick and you're on a ventilator, obviously that's not going to be, you can't control that. But anything short of that, many hospitals will let you manage your own diabetes, but if you don't have your pump supplies and you don't have what you need, then you're not going to be able to do it. But again, I don't even care if they say you can't test your blood sugars. No one's going to stop you from doing it or looking at your sensor. I mean, you need to know. I mean, you're your own best doctor when it comes to your diabetes. Nobody but you knows your diabetes. Yes, we healthcare providers can help you. And yes, the hospital's a different setting. But one of the things about COVID-19 is that oftentimes you feel sick, but not that sick. And then about halfway through, you get really sick. So just because you're not hitting that wall of having a breathing problem, you really want to be prepared. And so just the first sign of sickness, what I tell my patients, and I've only had one patient that I thought had it and helped them and actually helped keep them out of DKA, but the same way I said, I just made sure that I was able to give, have ketones. They had positive ketones. I gave them more insulin. I gave them carbs. They felt like crap. They didn't want to go to bed. I mean, you can treat someone, it's fine. But I just want to make sure that people aren't caught by surprise. So I tell all of my patients that the first sign of a fever, they let me know. And so if anybody, and again, because this is going to be around for the next year or so, I just want to know as a doctor. And if I think someone's sick, then every day I'll just check in. And then if they do fine, they do fine. And as far as I can tell, most people do fine. But those who don't, I want to know so I can, guide them. Now I can't breathe. Now I'm feeling short of breath. Now I have to go to the hospital. I want to know. So it's a kind of thing where if you get sick in the next year or so, you just want to be extra vigilant about yourself and communicating with your healthcare team. It's just the surprise components. And I can't predict COVID-19, and I've seen it in people without type 1, and it has various different flavors to it. So most of the time people are fine. Like I said, I still haven't had anyone in the hospital, and I still haven't had anyone die. So, it's survivable for most people, but you've always got to be prepared for the worst outcomes.
Excellent. And then I think those were all the main questions, but while I have you, I do want to ask, we did get a couple questions about, and let me see, make sure I pronounce it right, about hydroxychloroquine, or if you had any thoughts on that, on the HCQ, just in general, and then I guess more specifically if there was any diabetes concerns, like if anybody had diabetes and was thinking about taking it or thinking about participating in a study with it. So what do you know about HCQ?
Well, so hydroxychloroquine is an old drug, and it's a derivative of chloroquine. And any of you who are as old as I am who traveled to Africa took chloroquine. And chloroquine is a really nasty drug. It makes you feel sick, and it can cause cardiac arrhythmias, and it can also cause trouble with your retina. And hydroxychloroquine is actually easier to take, and it's been used for treating rheumatologic diseases, and it's had a role. The problem with it is that even though it treats malaria, we haven't proven that it treats a virus. And so they've studied it for influenza, and it didn't work, even though in vitro, in a test tube, it seems to. But there were early studies from Wuhan in China where they gave people hydroxychloroquine and chloroquine, and they seemed to do better than those who didn't have it. And then they did a study in France where the same thing seemed to happen. But the problem is none of those patients were clean, meaning they just got that drug, because in China, they were giving them all sorts of HIV drugs and all sorts of other things. So we don't have a really clear randomized controlled trial that says it works. It might help. There's a reason it might. It helps prevent malaria, but this isn't malaria. So there've been a number of protocols, and most of the people, the healthcare providers in places like New York, or not, I don't know if it's most, but I certainly know a number of them have been given hydroxychloroquine to try to prevent the severity, the progression of the disease. And I haven't felt like it's been a huge benefit in those people from what I know from reading the case reports. But there is a theory that if you take it early, that it might help prevent disease. And the problem with hydroxychloroquine, again, is that it can affect the retina. And anybody with retinopathy, I personally think, shouldn't take it. And the second thing is it can cause cardiac arrhythmias, and it could kill you, which is kind of bad. These side effects, by the way, have been known for like 30 years. If you happen to learn about these drugs, you would know that they have bad side effects, and that's what's in the package insert. So anybody could learn about these if they wish to. So my feeling is if somebody wanted to do it, I'm not opposed to hydroxychloroquine. I don't want to mix it with azithromycin, which is what they did in a small subset of 5 patients in France, because azithromycin further worsens that effect on the heart. And because there may be some micro damage to the heart from diabetes, who knows? I'm just careful about the heart. So I think a lower dose of hydroxychloroquine might be okay early on, but it's not a standard of care. I don't even know that I would take it. I have hydroxychloroquine at home in case I need it, because I'm internally prepared. But I don't know. There's a study in Minnesota where healthcare workers who are exposed to the virus, or if you have family members who have it, where they're giving you a weekly dose of hydroxychloroquine to prevent the virus from attaching into your system. And they give you like a double dose the first day, which is 800 milligrams, and then a week later you take the usual dose, 400 milligrams. And I have enough patients who've been on hydroxychloroquine for their rheumatologic diseases to not be afraid of regular doses of it. And that's the high dose one day and then the follow-up. But maybe that will work, but they're doing studies to look at it. So we'll see, but I'm pretty sure, if you want my guess, is that it doesn't help you later on to prevent severe disease, but it may help you early on to prevent getting it or progressing from the beginning. The real treatment, I think, that may work is something called convalescent plasma, which means you take the plasma from someone who's had the disease and you give it to somebody who's critically sick, and that gives the person antibodies and it helps them get over the critical sick phase. That's worked with a number of other disparate kinds of diseases, including viruses, and there are studies at major medical centers ongoing where they do this. So that to me seems like something that could help. And it actually, when people ask me where they should go to the hospital if they think they have COVID-19, I say go to a major medical center. Don't go to your community hospital, because the major medical centers are doing these clinical trials that are looking things like the convalescent plasma or this antiviral called remdesivir, which is a big trial going on, which I'm also not sure is going to work. It flunked with Ebola. But the problem, again, is that drugs look really good in a test tube. They're effective, but then they're not actually effective against the disease in actual humans. So that's a very long answer about hydroxychloroquine, but all drugs have side effects. And unless we have a really compelling reason to think it works, then I would wait, especially if you had retinopathy or any cardiac issues, because you don't want to be dead from the drug. It's kind of a bad idea.
Yeah, death is not a very good side effect. We'll try to avoid that one.
Well, and that's the whole point of this, is first of all, by the way, I think that COVID-19 is a nasty virus in some people. And even the people who don't die have a long recovery from it. And then again, there are people who get just mild disease and are fine. But, most of the people I've talked to that I've seen have it, it takes a lot out of you. So that's why I'm not thrilled about people just wondering about getting it. I mean, I think it's worth preventing getting it. But we all read all the stories about all these people who die from it. And, that's obviously the bad worst outcome. And that's where all this research is ongoing to try to prevent, people with that terrible pulmonary process from dying. And, we'll get there, but it's going to take a while to get the clinical trials data back.
Great. Well, thank you so much. As always, this has been very enlightening. I guess I would just ask, is there anything else? Have we learned anything? I know we've been speaking for about a month now and 2 weeks since we last talked. Any updates or news about coronavirus and diabetes that we haven't touched on?
Well, yes and no. So we don't know anything more about type 1 diabetes. We don't know anything more about diabetes because no one seems to have measured A1Cs, but they're kind of too busy like saving lives. But what is interesting, and data that came out of France, is that BMI, body mass index, is very closely related to outcomes. I mean, actually frighteningly so. So if you look at the people who die, most of them are heavy. And there's something about being heavy that seems to increase your risk of death from coronavirus. And we think it may be, don't quote me, right? I'm not an expert, but that somehow being heavier puts your lungs in a worse position. It's harder for you to breathe deeply, and the pressures on your lungs are different. So they've even found that if in Italy they did this, they took people and normally they're on their back like this on a ventilator, that if you tip them and put them prone on their stomach, they breathe much better and they might not even need to be intubated. So breathing, your position makes sense. And CPAP in some cases has been helpful because you've got to be able to oxygenate your lungs. But that being said, if your body mass index is greater than 35, you're at much greater risk of having bad outcomes. And as you go up in body mass index, the risk gets higher. So above 30 is considered obese. And a lot of people with type 1 diabetes, have issues with weight. And what I would argue is that if anything motivates people that are sitting around right now to work on weight loss and exercise, it's now. So the healthier you are, truly the better your outcome is going to be. So this isn't really for type 1s as much as it is for everybody in the population, because type 1s can be overweight, but no more or less than anybody, right? Type 2s often are overweight. So the notion is the more you can use that thought to, shed a few pounds and be healthier, you improve your outcomes. So it's not a type 1 diabetes bit of advice, but it's certainly clearly associated with bad outcomes in general. And diabetes less so. It's the weight. That's why we saw it's weight and age and male gender, sorry. But, and you're not heavy, but, I'm just pointing it out that there's a number of confounding variables here that worsen outcomes, which looks like diabetes bad outcomes, which isn't when you separate it out.
Yeah, I know. I've been hearing that for a few weeks now, that men tend to do much worse. So I will bank on being relatively fit and young for now. But great. I think that's all super helpful. And we do have an audience of type 2 and type 1. And it's just good advice for everybody to stay active, keep exercising. Don't just,
Well, no, it's always good advice. But yeah. It's like you feel like you can't do anything for this. Well, actually, I think keeping your lungs healthy and exercising and, if you're supposed to wear CPAP, wear CPAP. I mean, do the things that keep your lungs expanded. I mean, it's an oddball thing to say, but if just turning someone over prevents you from having to intubate them and increases their oxygenation, there's something really positional. And, these are all like folk things, but I like little things that add up to health. I don't like fancy things. It's like, let's do simple things and keep healthy. Oh, fancy things, except I love technology for my patients. I guess I'm a liar.
Right. Great. Well, thanks so much, Anne. It's always great to talk to you. It's been a pleasure, and hopefully we'll be able to do this again soon.
Absolutely. Take good care of yourself. Okay. Bye.